The first presenter is Dr. Pooja, and topic is to compare efficacy of supratarsal triamcinolone injection and autologous serum in recalcitrant VKC. You can start, please.
Good afternoon, everyone. At the outset, I would like to thank AIOS and esteemed judges who are present here. A very good afternoon, one and all. So today I'll be presenting a paper on to compare efficacy of supratarsal triamcinolone injection versus autologous serum in recalcitrant VKC. Nil financial interest involved in the study. VKC is a bilateral inflammatory disorder of conjunctiva and cornea, which is commonly seen in first and second decade of life. Serious side effect associated with steroids, incomplete amelioration of the symptoms with other drugs, and requirement of long-term installation of drugs necessitated the study of other therapeutic agents. In VKC, increase of the T helper 2 cells occurs that leads to overactivation of these cells, giving rise to hypersensitivity reactions. And autologous serum is mainly targeted basically in order to shifting of the helper T2 cells to the Th1 cells. The aim of the study was to compare the safety and efficacy of supratarsal injection of triamcinolone versus autologous serum in recalcitrant VKC. The study was conducted in the Department of Ophthalmology at Adichunchanagiri Institute of Medical Sciences, BG Nagar, Karnataka, over a period of 18 months from July 2020 to December 2021. It was a prospective, non-randomized study which included 40 eyes of 24 patients. We divided into 20 in each group, Group A and Group B. After obtaining institutional ethical clearance and a written informed consent, the study was performed. We included all recalcitrant cases of VKC, which was diagnosed on the basis of persistence of the symptoms. And exclusion criteria was glaucoma or raised IOP, previous history of any ocular surgery or trauma, children less than 5 years, family history of glaucoma, patients with connective tissue disorders and high myopia were excluded from the study. Previous medications were discontinued for a period of 15 days before commencing autologous serum or triamcinolone injection. Complete ophthalmic evaluation was performed, which included details of the symptoms, best corrected visual acuity, slit lamp biomicroscopy, IOP, and fundoscopy was done. Family or personal history of allergic disorders was also taken into account, and symptoms and signs were graded and recorded according to Tahir et al. So these were the few of the presentations noted in our study with cobblestone appearance of the papillae and the Horner-Tranter spots. Basically, autologous serum was obtained after centrifuging 20 ml of blood for a period of 10 minutes, and serum was obtained. 0.5 ml of triamcinolone was injected in Group A and 0.1 ml of autologous serum in Group B in each eye supratarsally. Injection was repeated once a month in Group A and every fortnightly for 8 weeks in Group B. And follow-up was done in all at 1 month, 3 months and 6 months interval. So the data was entered and analyzed. So we obtained results as shown in the table. At the period of 1 month, there was not much of significant difference between the two groups. Symptomatic improvement were noted in both the groups. At the end of 6 months, though not statistically significant results was obtained, but definitely a larger proportion was noted in the Group B, that is with autologous serum. This table shows improvement in signs in both the groups, again not statistically significant, but definitely a slightly higher amount, that is nearly 95% in Group B patients. So this was at presentation. All these cases were given autologous serum. At the end of 6 months follow-up, definitive resolution of symptoms has been noted. VKC is a chronic bilateral seasonally exacerbated allergic inflammation of tarsal conjunctiva, bulbar conjunctiva, or both. In our study, it was most commonly seen in age group between 5 to 23 years and stronger predilection among boys, which is in comparison to other studies. Improvement in symptoms at 6 months follow-up was seen in 80% and 90% in group A and B respectively, and resolution of signs was seen in 90% and 95% in group A and B respectively. The pathogenesis, as earlier told, basically autologous serum targets the T helper 2 cells to the Th1 cells, reducing the IgE mediated reactions. So serum also exhibits characteristic properties which are similar to those of tears regarding pH and osmolarity, which helps by providing symptomatic relief. Limitation was long-term follow-up was required for this in our study. To conclude, autologous serum in recalcitrant VKC can be given supratarsally as a safe alternative to triamcinolone. Thank you one and all.
So, nice presentation.
Thank you, ma'am.
I just want to know any side effect of triamcinolone?
Side
or
effect?
autologous serum?
No side effects as such were noted, ma'am. Basically, we are telling that it can be used as a safe alternative to triamcinolone, like in order to reduce, increase in intraocular pressure is known by giving repeated injections. So probably it can target that issue as well. And autologous serum mainly it directs the T helper 2 cells to the Th1 cells, which reduces the IgE mediated response in the ocular surface.
Suppose intraocular pressure is not an issue.
Okay,
So
sir.
in that case also you advocate giving.
And also most of the cases may be associated with dry eye also. So autologous serum can also be used as a drops in treatment of dry eye. So it can target both. If you're giving supratarsal injection, it can target VKC as well as it can be addressed for dry eye also.
So it's a safe alternative.
Safe alternative. Definitely, not much of significant difference was
Yes,
noted
exactly.
in terms of signs and
5%,
symptoms.
90 and 95, it doesn't
Yes,
make
sir.
any
It was
difference.
not
Okay.
better.
But it can be used as a safe alternative. No side effects as such with the autologous serum.
Only in contraindicated patients you can use it. Other routinely you can use.
You can use it, ma'am.
Okay, thank you.
Thank you. Autologous serum can be stored up to 1 week, but in all these patients, we were repeating injections once in 2 weeks. So we had to freshly draw the blood each time they came.
Thank
You are
you so
Dr.
much.
Pooja.
Yes, sir.
Yes, okay.
Thank you, Dr. Pooja.
Thank you,
Next
thank you.
speaker is
Thank
Dr.
you.
Samrat Chatterjee. So he will be speaking on clinical differentiation between pythium and fungal keratitis.
Good afternoon, respected members on the dais and distinguished friends. So I shall be talking about clinical differentiation between pythium and fungal keratitis. There are challenges in differentiating these two infections. I have no financial disclosures to make. So let's take with a case example. This patient had come to us with a corneal ulcer that clinically appeared to be fungal, and the direct microscopy reports also showed of the scraping showed fungal filaments. So we treated the patient with antifungal drugs, but the case worsened, and we advised a therapeutic keratoplasty. The initial period was uneventful, but soon she came back with florid recurrence that soon progressed to perforation, and we lost the eye. Meanwhile, the report of the corneal button had come, and it had grown pythium insidiosum. So we had been treating this patient as fungal keratitis while it was actually pythium keratitis. But what had happened with us is not uncommon. Misdiagnosis has been commonly reported in the literature, and it is mainly because clinically the fungal ulcer appears like the pythium ulcer, and on direct microscopy, both the filaments are sometimes very difficult to differentiate. So we thought if clinical signs can be a clue, if they can aid in the diagnosis of pythium initially, so that we can have avoid such poor outcomes. So we did a retrospective comparative case series where we included culture positive pythium keratitis and culture positive fungal keratitis and examined their clinical reports and archived photographs. So these are the signs that have been reported in literature for pythium keratitis and fungal keratitis, and we concentrated on these signs. So there were 27 patients with pythium keratitis and 69 patients with fungal keratitis. Amongst the demographics and the risk factors, an absence of trauma was noticed more commonly in patients with pythium keratitis. Trauma was associated with fungal keratitis. Although, excuse me, the age of the pythium patients was slightly younger than fungal keratitis, it was not significantly different, but the symptom duration was same in both. However, the ulcers of pythium were larger and the vision was poorer, more severe infection. If we look at the excuse me, if we look at the clinical signs, dry surface, which is classically associated with fungal keratitis, was seen more often in patients with pythium keratitis. Plaque was much more present in fungal keratitis. High-weight ulcer margins was much more present in fungal keratitis, but tentacles were more commoner in pythium keratitis. Intrastromal dots were characteristic of pythium keratitis, but they were also seen in patients with fungal keratitis. The reticular pattern, which is a very classical sign, was also seen in patients with fungal keratitis. Peripheral furrow, that is now recognized as an important sign, could also be seen in patients with fungal keratitis. And a ring-shaped ulcer was much more associated with pythium keratitis than fungal keratitis. Other signs like color of the stromal infiltrate or the satellite lesions were not found to be statistically significant. We did a multivariate logistic regression, and where we found that a peripheral furrow and presence of tentacles were more associated with pythium keratitis than fungal keratitis. So we thought that these clinical signs, although they were associated with fungal keratitis, but awareness of the clinical signs would alert the ophthalmologist in the clinic to make a presumptive diagnosis of pythium keratitis. They in turn can alert the microbiologist, who can be more careful in their evaluation of the corneal scrapings. And sometimes when this, the situation is, culture reports are ambiguous or negative or delayed, then this clinical approach can be helpful in the clinics to make a therapeutic decision. Ophthalmologists who do not have access to microbiology can recognize these signs, and they can, refer the patients early, because pythium progresses very fast and can have a poor prognosis, poor outcome if treatment is delayed. If we go back to our patient whom we had misdiagnosed as fungal keratitis, we found that he had tentacles, reticular pattern, and intrastromal dots that were not picked up. So it is possible to differentiate pythium from fungal keratitis, but there is overlap of signs, and none of the signs can be considered as sine qua non. So one solution is to develop a clinical score by combining these signs into a compact score, which we have done, and we presented the findings in the morning. And however, I would like to clarify that clinical approach or clinical diagnosis can only be an adjuvant. It does not replace the role of microbiology. For microbiology's evaluation remains the gold standard for diagnosis of any infectious keratitis. But the clinical approach can be an adjuvant and can actually help the clinician when the microbiology reports are ambiguous, delayed, or negative. Thank you.
Very good presentation, Dr. Chatterjee. What is the difference between the treatment protocol in these two cases?
It's completely different because pythium keratitis needs to be treated by antibiotics. Currently, azithromycin is one, linezolid is the other. There may be more antibiotics, but they cannot be treated with antifungals. They do not have ergosterol in the fungal cell wall, so the antifungals do not work. But because fungal keratitis is more prevalent, so when you have a case that is that overlaps and you don't have a good microbiology report, the fungal filaments and pythium filaments, sometimes they are very, very difficult to differentiate. Then the obvious tendency becomes to treat it with antifungal drugs because of the prevalence. Pythium is around, studies reported from 1 to 6%. In our setting, it is around 1.4%. And fungus is around 50%. So you can commonly misdiagnose a pythium for fungus. But these signs are actually helpful more if we combine them into a clinical score. And we presented that clinical score data in a previous presentation in the morning. And that is more helpful than just picking one sign. So it has to be a comprehensive approach with the clinical science.
And a typical history found in Pythium?
See, typical history that we found, and also that's reported in literature, is absence of trauma. So, but that's again a very vague history, because normally we associate a vegetative trauma with fungal ulcer. So maybe a clinical ulcer that appears to be fungal, and patients deny a history of trauma, then you can probably suspect that maybe it's Pythium and look much more into the microbiology, alert the microbiologist. If clinicians are alerted, then they can in turn alert the microbiologist, and they can pick up more signs.
In your group of Pythium keratitis, you didn't find any trauma? No one gave the history of trauma?
Less trauma.
And in your series?
Yeah,
how
in my
many
series
cases
also.
were?
In my series also, the percentage of trauma was much more in the fungal keratitis.
But there was history of trauma.
Yeah. So there's an overlap of signs, even history.
Also.
Some studies, I think from Shankar Netralaya, they had not presented any trauma in one of their papers, and few of the initial case series of 2 or 3 cases did not have history of trauma. But trauma can be there, or sometimes maybe the trauma is missed and the patient doesn't associate it with it.
Trauma again with this typical vegetative material, like we see in
trauma with anything. In fact,
anything.
Vegetative matter is a secondary infection that occurs. Even in bacterial keratitis also, you'll get a history of trauma sometimes even with vegetative matter. So the trauma creates an epithelial abrasion, which can then get infected either by fungus or bacteria, depending on what the patient is exposed to.
In general ophthalmological practice, it's not an uncommon thing that we see that the patient, usually they mix antibiotic with antifungals. How do you see that?
But here the antifungal that they mix is what, moxifloxacin, and it has not been found to be very useful with Pythium. So we're using linezolid, which we have to make it, or azithromycin, which is also not a very common frontline drug. So because it progresses rapidly, in our case, the case worsened in days. So a comprehensive ophthalmologist treating this with both moxifloxacin along with antifungal drugs, and then calling the patient after 3 days or 5 days, by the time the case would be out of your hand. So initially only if you suspect that, okay, this doesn't look like a typical fungal ulcer, better that I should refer it to a place where they can do a corneal scraping. That would be, so that is actually the aim, and that's why I put this first part of the paper in the comprehensive, this thing to alert comprehensive ophthalmologists that if you see these signs in a patient with a corneal ulcer that appears to be fungal. Now Candida and Dematicious have typical features. So this is mainly for the hyaline fungal filaments. So at that time, best is to send it to a place where there's a good microbiologist, and the microbiologist knows how to pick up the Pythium.
You said culture was positive for Pythium. So which culture media you had used?
We have done blood agar. So blood agar is not the definitive culture medium, but it gives a kind of a typical colony. It's a flat colony, grayish, translucent type of a colony, which is homogeneous. And from there you can again get the filaments. But normally the diagnosis is you have to use some other techniques where it includes seeing the sporangiophore. It's not done. Even our microbiology is not equipped to do that. Most of the microbiologists cannot do that. And DNA, that's if the government RT-PCR labs, they can get this thing, what do you call, generalized into other investigations of the COVID is over, maybe. Otherwise, diagnosis culture is difficult.
Even filaments, they are like ribbon shaped, and they've got some vacuoles or vesicles inside the filaments.
Yes.
So that is quite characteristic about Pythium.
Yeah, but then if you see, I had quoted it, a recent paper from L.V. Prasad. They had actually done a sensitivity among 3 microbiologists, and all these 3 microbiologists were experienced ones who first reported. And there also the lower limit of the confidence interval is 79.3. So from such a big center who have been seeing Pythium for 7 years, they are in 20% of cases, they are not able to identify it on direct microscopy.
Thank you, Dr. Chatterjee.
Thank you.
So now we'll move on to third presenter, Dr. Avik De Sarkar. Dr. Avik De Sarkar. question answer later on because we are running short of time.
In acute central serous chorioretinopathy, new approach in management. CSCR is serous detachment of neurosensory retina with accumulation of fluid. The exact pathogenesis is inconclusive. It's the only retinal disease involving fluid accumulation which is not improved but even worsened by corticosteroids. Therefore, the link between corticosteroids and CSCR combined with the observation with an induced CSCR-like model in the rat following mineralocorticoid receptor pathway activation has prompted the evaluation of eplerenone, an MR antagonist, in the treatment of CSCR. Eplerenone is a selective aldosterone receptor antagonist. It's a potassium-sparing diuretic with adverse effect of hyperkalemia. It's a randomized prospective comparative case series done over 3 years where the patients with acute CSCR presented for the first time over 18 years of age have been included. All the patients were divided into 2 groups by alternate random sampling in group A, treatment group, and group B, placebo group, where group A treated with oral eplerenone 25 milligram per day for 1 week and then 50 milligram per day afterwards till the complete resolution of SRF or till next 3 months, whichever was earlier. But the group B patients were on oral medication of vitamin B complex once daily after dinner. The follow-up period was 3 months. So the data collection algorithm was BCVA on Sillens chart, SD-OCT evaluation for CMT analysis and presence of SRF and serum potassium levels. All these parameters were checked at baseline and every monthly visit till the end of the study. We have total taken 162 eyes of 162 patients where the age was showing adult population with generalized male preponderance. In terms of resolution of SRF, though the baseline CMT was showing comparable in both the groups, but the change in CMT was significantly higher in group A for all the months compared to group B. For complete resolution of SRF, in month 1, 55% of patients achieved in group A compared to 22% in group B, while after 3 months it is 96% in group A compared to 83% in group B. In terms of improvement in visual acuity, again the group A is showing better results compared to group B in terms of BCVA improvement. BCVA improvement to 6.6 was achieved in 72% of patients in group A compared to 49% in group B in month 1 and 96% in group A compared to 83% in group B. After 3 months, the 4% of group A patients have progressed to chronic CSCR, while 17% of group B patients have progressed to chronic CSCR. The change in serum potassium in group B was minimal compared to group A, where significant increase in serum potassium have been seen after 3 months. These are 2 representative OCT images showing almost comparable SRF and CMT at the baseline in group A and a group B patient. But after 3 months, group A patient is showing complete resolution of SRF, while in group B, there is minimal SRF still been persistent and progression to chronic CSCR. So on discussion, in a study by Venkatesh R. et al. Shown BCVA of 6.6 was achieved by 100% of treatment group and 100% of control group at the end of 3 months. But in our study, the 6.6 was achieved in 96% in treatment group and 83% in control group. Zucchiatti et al. Demonstrated a complete resolution of SRF in 80% of cases in treatment group and 25% of cases in control group at the end of 3 months. Sun et al. Investigated the effects of spironolactone versus observation in patients with acute CSCR and found similar results to our study. So although the difference in level of serum potassium in both the groups showed no statistical significance at baseline, but there was a mild increase we have noted in the treatment group compared to the control group at the end of 3 months, which was significant statistically. Eplerenone has a meaningful effect against the inappropriate activation of the mineralocorticoid receptors found in the choroidal vasculature in the patients of CSCR. So the basic motto of our study is the addressing the unmet need, both in terms of SRF resolution and in BCVA improvement. We have shown that the group A, the treatment receiving patients are showing better results compared to the control group. So we conclude that a higher and a faster resolution of the disease was achieved in treatment group in acute cases. Patients undergoing eplerenone therapy showed lesser propensity of progression towards chronic CSCR with permanent RPE changes. In our study, 14 patients from control group progressed to chronic CSCR, while only 3 patients from treatment group had the same fate, which is statistically significant. So we say that Eprenone may represent an attractive new first-line treatment option for acute CSCR. These are my few references. Thank you.
So, thank you, Rohi. Now I will call Dr. Santosh Mahapatra, the next speaker. He is going to give keynote address also later on. So, Santosh.
Good afternoon. I am going to present 52-week results of safety and efficacy of optogenetic therapy for vision restoration in advanced retinitis pigmentosa. I was the principal investigator for the study. I have no financial interest, but all the papers related to ethical clearance and gene therapy related are submitted to scientific committee last year, because I presented the 16-week primary endpoint report in the previous AIOC. So why optogenetic gene therapy? It's because the available therapy for advanced retinitis pigmentosa, like use of electrodes, are invasive in nature and has limited resolution. And the classical mutation-specific gene therapy requires presence of photoreceptors like the rods and cones, which are not available in advanced retinitis pigmentosa. But the optogenetic therapy targets the other cells available in the retina to modify them to photoreceptor cells, and that's why optogenetic therapy is a promising option. And here we introduce a special gene that enables the neurons to be stimulated in response to light. The earlier monochromatic opsins like channelrhodopsin, which are used, required intense light to be stimulated and produced suboptimal neuronal response, which requires wearing of goggles to stimulate the retina. But in contrast, the advantage of polychromatic MCO is that it is activated in ambient light, generates significant photocurrent, and does not need a glass to get activated. And the approach is to turn the bipolar cells into the photoreceptors. And the method is a very simple intravitreal injection of the MCO into the vitreous cavity. And the target cells are bipolar cells. So here is the flow, how the study goes. The key enrollment criteria is either perception of light or hand movement in the study eye, and no better than counting finger in the fellow eye, regardless of the RP gene mutation. The subjects were divided into 3 groups. First was the low group of 3 subjects. The second one was a higher group of 3.5 into 10 to the power 11 vector genome per eye, which was well tolerated, and the next group of 5 subjects were given the same dose. The demography showed that we have 6 males and 5 females in our study, and this is a panel of pictures showing neutralizing antibody in the serum of the VMCO treated RP patient, which are done at 4 weeks post injection, and none of the patients developed neutralized antibody to the injection. And here is the gene panel for the study subjects of advanced retinitis pigmentosa. Out of that, the most common gene was ABCA4, which was detected in subject number 5, subject number 8, 9, and 10. And here's the study safety profile, which shows that none of the subjects developed more than 2+ AC or vitreous inflammation. 5 out of 11 required no medical treatment, and 2 out of 11 had only moderate rise in intraocular inflammation, and 5 had moderate elevation IOP, which are well controlled with topical medication. More importantly, no subjects required oral steroid or glaucoma filtration surgery to treat the increased intraocular pressure. There was no detectable retinal toxicity assessed by OCT imaging. And the Freiburg visual acuity improved that few weeks after VMCO injection, subjects have more than 15 letters gain in 87% of the subjects and more than 30 letter in 75% of the subjects. And here is the fundus autofluorescent photograph of the patient, which shows that the M-cherry expression is very good, which is being depicted by conversion of bipolar cells into the photoreceptor cells. And is a Y mobility test tells that most of the patients improved on mobility score. Here is a videos which one of our patient, when asked to move on Y mobility test to locate the light pre-injection and post-injection, you can see the behavior of the patient. This is the pre-injection movement, and you can see the patient is trying to locate the light but not able to do so, even if he comes very close to it. And this is same patient post-injection, which when he is asked to locate the light, you can note the way he is moving and the way he is locating the light. So to summarize, there is very favorable safety profile with no serious adverse effect, mild increase in IOP and intraocular inflammation, which are well controlled with topical medication. There is no increase in neutralizing antibodies against the VMCO, suggesting no systemic immune response. And the dose-dependent efficacy was very good, which is depicted both in increase in visual acuity as well as functional vision in Freiburg visual acuity, Y mobility test, and NEI vision questionnaire functions. With this encouraging results, a randomized double-masked controlled multi-center phase 2 trial is on the way in US at 6 centers. I would like to thank my co-investigators and authors for this wonderful study. Thank you.
Santosh, what was the age group? Means you tried in which age groups?
The age group was more than 18, and it was the oldest patient was 73 years old.
73, 18 to 73.
Yeah, no children were included because this is a new study which involves gene therapy. All the adult populations were only included.
Okay, very good, very innovative. Let's hope that it works.
As because sir, I have the keynote address of 16 weeks and this is 52 weeks. I want to just forgo that keynote presentation in interest of the competition.
You want to continue this?
No, I don't want to present because that's a 16 week.
Okay.
I want to forgo that.
Okay.
Because I am competing for that.
Sure. Thank you.
Okay. Thank you, sir.
Thank you, Santosh. So now I call Dr. Prasanna Venkatesh Ramesh.
Can I have my slides?
Yeah, please.
Yeah, it's here.
It's here.
Thank you for this opportunity. I'm going to talk on an application in ophthalmology, an app which we innovated called the IMG3D. So this is a three-dimensional app targeted for neophytes, residents, for teaching purposes as well as for counseling. So most of the applications today, there are so many apps in ophthalmology. There are 2D and 3D animated images is what there is available currently in the market. So our aim was to build a novel app which uses real images, and we have done it using real-time confocal patients' own images with wide field 110-degree true color confocal images, and the gonioscopy structures, as you can see, the slit lamp structures, they were all real structures were used. We used the Unreal Engine software to actually keep a sequel of 12 cameras to 16 cameras inside, and we gave the power of choice to the user so that they can choose whichever frame that they want to choose. So this is the application name IMG3D. Once you open the app, you have 3 buttons called the anatomy, pathology, and the videos. And the videos are also available in real-time 3 dimensions. So we wanted to solve the problem statement of creating an app which is as real as possible to the patient's real-time images for learning. So you can see here, once you click the anatomy button, you have a dynamic feature where it's not a static app, it's a really dynamic app which gives you the eyeball of the patient. And now they can choose anterior segment. By clicking on the anterior segment, you can click on angle and see the gonioscopic structures in real time. And also the electron microscopic view, if wanted, can also be chosen by clicking on the trabecular meshwork. So you wanted the choice of learning to be there for the neophytes and the residents. Similar thing goes in for the posterior segment as well. So this is the vitreous on and off can be done. Similarly, silicone oil on and off buttons are also catered. So the fovea can be studied as well as the optic disc. So these are all the normal structures that we provided in the application. So from the normal structures, we started updating a multimodal imaging atlas as well in the pathologies. So all the pathologies such as complex pathologies, you can just go to the pathology section. There is a flecked retina here, for example. The color fundus is there. You can choose autofluorescence. You can choose an infrared. Along with the annotations, a comprehensive multimodal imaging atlas is provided. And also you can see that a splinter hemorrhage, for example, if it is chosen, it can be seen in infrared, and the same infrared can also be focused by zooming in and viewing. And also you can go back. Now you can choose, for example, fibrovascular band. Again, you can see the disc, or you can go to the periphery and you can see. So there are a lot of dimensions that are there in this app. If a retinitis pigmentosa is there, we have given an autofluorescence. It's more like a multimodal imaging atlas or a book that we have given with normal patients, flecked retina to summarize, a fibrovascular band. Not only the fundus, we get a total of all the filters that you want, a glaucoma nerve fiber layer defect, myelinated nerve fibers, splinter hemorrhages. So this is the innovation that we did with neovascularization elsewhere, and more pathologies are keeping on adding once every 2 weeks in this teaching app. Even if you see the videos, if for example a central retinal vein occlusion video is chosen, the whole dimension of this is shown as an unanimation. It's not an animation, it's an unanimation. This is how it happens in the real time. You can see real time fundus and how the block actually causes a central retinal vein occlusion can be shown in less than 30 seconds. It's like a snippet for them to really learn the pathology. So this is a video showing the tomato splash appearance and then summarizing the RAPD that can be seen in this patient. And you can see that it goes in and it just shows. These are all dynamic features which the users can actually choose. So the RAPD can be shown, and if not treated for 90 to 100 days, it will go into a neovascular glaucoma. So concepts which are very complex can also be summarized in a very short 30 to 40-second videos are also available. So it's not only anatomy, there is pathology as well as this. So what we then wanted to validate this app. So we also gave it in Windows. If people are not comfortable in phones, the bigger display Windows is also available, and this is what it is. We assess the satisfaction level of the classes taken for first year postgraduates with the IMG 3D app and without this. It was a cross-sectional study conducted with the users who downloaded this, a comparative study regarding the questions pertaining to the knowledge, comprehension, graphics in the app, gamification, tutorials, innovative representation, and the additive 3D features. So the invitations were sent through Google Forms. 217 invitations were sent. We had 203 respondents. We had more than 500 downloads for this app actually. And the study period was actually 1 week. So in that we got, these were the feedback. The satisfaction levels were classified as satisfied, neutral, and dissatisfied. The discrete variables were converted into a continuous variable, and paired t-test was employed. And the p-value that we got was quite significant. The pie diagrams will be following. So what we wanted to see is how does the app really cater to the residents or the neophytes we wanted to evaluate. The student satisfaction when they read some complex things to the IMG app was much better. It was more than 90%, 96%, and the satisfaction level was 89%. It's not that different, but the experience was slightly immersive. So that made the difference for a pedagogical transformation with this teaching app. And also for counseling, a simple YAG-PA, anti-VEGF, or a trabeculectomy or a retina surgery, when you use real-time images, it really makes a difference where we slightly move from animations to unanimations. So according to our knowledge, there is no application to date in ophthalmology which uses real-time confocal multimodal images and photoreal visuals for interactive 3D learning. We wanted to bring unanimations into ophthalmological app making to make these concepts for pedagogy and counseling. This is available, and if you can scan the QR code and get this app in your Android phone. Thank you for the time.
Thank you, Dr. Mahesh. It was a very innovative, definitely wonderful.
Very innovative.
Thank you, sir.
Okay, we'll take up the discussion after we finish the session because we are running short of time. So next I will invite Dr. Kavyan Asokan. लेकिन you cannot ये मुझे लगता है इसी पे जज करना पड़ेगा देख लेते हैं अगर suppose
Good afternoon. I am presenting a paper on dry eye among healthcare workers wearing masks during COVID-19 pandemic. After COVID-19 was declared pandemic in March 2020, government health authorities made wearing of masks compulsory. There was increase in dryness among regular mask users, and previous studies have assessed the dry eye disease symptoms in mask wearers, but objective assessment of dry eye among healthcare workers has not been addressed. The mask use will continue for months or even years, and the prevalence of dry eye will increase in the coming years. The objective of my study was to estimate the proportion of dry eye among healthcare workers wearing masks and to find the association of dry eye symptoms, tear film breakup time, and Schirmer's test with socio-demographic factors, duration of mask wear, ill-fitting mask, and the type of mask. My study was a cross-sectional observational study conducted in Tertiary Care Hospital in Puducherry after approval from the Institutional Ethics Committee, and sample size was 384 participants. We collected details such as demographic details, symptoms of dry eye, type of mask worn, duration of wearing mask, awareness of upward airflow, and basic slit lamp examination was done, Schirmer's test, and tear film breakup time was done. And the analysis was simple descriptive analysis, and categorical data were represented in percentage and continuous data by mean plus or minus standard deviation. And any p-value of less than 0.05 was considered statistically significant. Abnormal T-butt was considered as dry eye, and awareness of upward airflow towards eye as an ill-fitting mask. So this is a graph showing distribution of participants according to age, and most of the participants, that is 78.9% of the participants, were between 21 to 30 years. And current study showed no significant difference in DEDs, T-butt or Schirmer's test with age, which is comparable to other studies. Most of the studies on dry eye showed significant dry eye in elderly population. This may be attributed to a smaller number of study participants above 40 years of age in this study. Male to female ratio was 1:2.15, and most of them were doctors, that is 40.9%, and T-butt was found to be reduced in 89 participants, and ST was abnormal in 12 participants. And 37.8% complained of burning sensation, 27% complained of dryness, 24% complained of irritation, and 11% complained of watering. And the graph showing type of mask use according to occupation. Most of the doctors were using N95 mask, and the staff nurses were using mostly surgical mask. So all DEDs had a significant association with T-butt, and dryness and burning sensations were significantly associated only with Schirmer's test. And female gender was significantly associated with DEDs, which was in sync with the previous studies conducted. And DEDs were significantly more among doctors and nurses compared to attenders and technicians, which may be due to compulsory long duration of wearing mask due to direct contact with the patients. And eye burning was significantly associated with the type of mask. And significant burning of eyes were seen in participants wearing masks for more than or equal to 8 hours, and eye irritation was present in those wearing masks for more than or equal to 8 hours, though it wasn't significant. And significant dryness was seen in participants wearing masks for more than 12 months. And awareness of airflow indicates an ill-fitting mask, and DEDs and T-butt both had significant association with the awareness of airflow. Discussion. Proportion of dry eye disease among mask wearers were found to be 23.2%, and previous studies has concluded that face mask use decreases the tear film stability in patients with moderate to severe dry eye, and a higher prevalence of dry eye symptoms during COVID among healthcare workers wearing masks. And in our participants, the symptoms were significantly associated with both T-butt and Schirmer's test. And most studies support the increase in DEDs with duration of use of visual display unit and using air conditioning in the office environment causes a decrease in T-butt time, which causes eye irritation and an increase in dry eye symptom. And a few studies have also found worsening of DEDs in soft contact lens wearers using masks during COVID-19 pandemic. But there was no significant difference in DEDs, TBAT and ST with mobile and computer usage or air conditioner exposure or use of contact lens in our study, which was supported by the other studies. The limitations of the study was that we did not ask for any worsening of DEDs, and hence a proportion of dry eye may be an overestimation and might have included participants with previous dry eye, and we used only DEDs, TBAT and ST for assessment of dry eye, and further studies may include a wider spectrum of measurements which are related to DEDs to investigate more thoroughly the effect of mask use on the ocular surface. The strength is that our study had assessed the DEDs in mask wearers and also the objective assessment of dry eye such as T-butt and Shermas, and we also included ill-fitting mask in our analysis. Symptoms were likely to be more in females, doctors and nurses, and those with an ill-fitting mask. As the mask use is likely to last for months or years, the prevalence of dry eye may increase. So healthcare workers should be counseled regarding proper mask wearing, and simple tips such as placement of adhesive tapes across the mask at the bridge of the nose can prevent damage to the ocular surface. And this will protect against both dry eye symptoms and airborne transmissions. Thank you. These are my references.
Yes, he is not seen. Okay. Okay, thank you, Dr. Kavya. Since you are not a ratified member, so your presentation will not be considered for the competition. So now, next I will call Dr. Hirika Gosalia. Yeah. She
The
will be
efficacy of eye
yes.
water compared to the index finger for upper eyelid eversion. Eversion of eyelids is a common procedure done as a part of a routine ocular examination. It is performed by the help of the index finger and the thumb of one or both hands. It can also be performed with the help of cotton buds. The principle behind lid eversion consists of the combination of two forces, pulling force by the finger on the eyelash and pushing force with the fingers on the upper tarsus. Lower lid eversion can be easily done by pressing the lower lid margin or with the help of a cotton bud, but the exposure of the superior tarsal plate is difficult due to the stiffness of the tarsal plate. Eversion of eyelid is essential for patients with acute redness, foreign body sensation, for the conjunctival disease, contact lens wearer, and for lid inspection. It is a skill that varies and especially difficult in anxious and distressed patients. With the advent of the COVID-19 era, there is a potential risk of transmission of virus due to the exposure of the ocular fluids such as tears or conjunctival secretions from the examiner's fingers to the patient's ocular bare surface. Eye water is a cost-effective, innovative, do-it-yourself, non-contact lid eversion tool. The materials required to make is scalpel, coffee stirrer sticks, and double-sided tape. So you can see in the video how we are attaching these coffee stirrer sticks at one edge over the double-sided tape, and then we'll be cutting each of them with the help of the scalpel, and in this way we can see how easy it is to make and to use it. The video shows the application. We place the eye water at the margin of the lid and we just twist it, and we can see how beautifully it can expose the upper tarsal plate. The aim of my study was to compare the efficacy of both the methods, namely the routine index finger and the eye water tool based upper lid eversion, and also to compare the infection transmission possibility between the two methods. Materials and methods were: it was carried out in a tertiary eye care center. Ethics committee approval was taken. A written informed consent was taken. We took patients from age 18 to 44 years, and lid pathologies and lid swellings were not included in the study. The participant's head was placed against the chin and the headrest attached to the slit lamp. The left upper eyelid of all participants underwent both the techniques to avert the lid in a random order by the same trained clinician, involving the index finger and the eye water tool for lid eversion. A Google form was filled for the same. The name of the patient was registered along with the age, the gender, who is examining it, doctor or paramedical staff, the date. We asked the patients how comfortable it was, from very uncomfortable to very uncomfortable according to the visual analog scale. Then was the procedure painful, from no pain to unbearable pain. was the procedure comfortable for the examiner, very comfortable to very uncomfortable, and the time required was recorded with the help of a stopwatch for both the methods, and the number of trials required for successful lid eversion was also recorded. And we asked the patient and the examiner which would be the preferred method, and also the examiner was asked the same question. A culture swab was taken from the fingertip after both the finger based and the eye water technique to assess the growth of microorganism. So the results showed that the eye water was a little more comfortable for the patient compared to the finger based lid eversion. It was shown that finger-based lid eversion experienced little to mild pain, while eye water mostly was no pain. The examiner preferred both the techniques equally. The time required was a little more for the lid eversion by the finger-based. The mean age group was 24.6 a year, and the gender was male were 40%, females were 60%. Patient comfort wise, eye water was better. Finger based technique experienced no to mild pain. Eye water and finger based were equally preferred by the clinician with regards to comfort. Time required was was more for finger based. Trial requires were more for eye water. Eye water was preferred more by the patients. Finger based technique was not preferred by the clinician. Microorganism growth was seen more for finger based technique. There was no statistical significance seen with regards to comfort, time, and the area exposed. And eye water, the limitation was that the patient, every finger has a different thickness, because it becomes difficult to evert lids with the finger. Fingers are more cumbersome also because disinfection is more difficult. And lid eversion took only less than 8 seconds with the help of eye water. So questionnaire also was given and shown that eye water was preferred. And the number of trials were more for lid eversion with eye water as seen in the questionnaire. Conclusion was that eye water was equally efficient as lid eversion by fingers, but also more safe during the COVID pandemic, wherein there's a risk of transmission of infection, and also the patient experienced minimal pain. Thank you.
So the next speaker is Dr. Divya Trivedi. She's not there? So next speaker is then Dr. Devendra Maheshwari. Acha, okay. Dr. Drishti. Okay. So we can call the next speaker.
No, she's ready.
You're ready?
Yes.
Yeah.
Okay.
One second. Good afternoon, respected judges and everyone gathered here. My topic is to assess the intervariability in intraocular pressure measurement by using Goldman apprenation tonometer, rebound tonometer and non-contact tonometer in glaucoma patients. This paper holds no financial interest. As we all know, intraocular pressure reduction is the only established method in management of glaucoma. There are several methods for the measurement of intraocular pressure, all having limitation in terms of accuracy. An ideal tonometer is the one which gives an accurate reading in normal as well as disease state. It is minimally invasive, suitable to use in all, ergonomic, transportable and easier to standardize. But unfortunately, no such device has been found. Goldman apprenation tonometry is the gold standard which is used as reference in clinical practice. It is based on Imberg's fixed law and gives an accurate and reproducible measurements. But it is non-portable and the patient needs to sit in upright position. In thin corneas, it gives an underestimation and in thick corneas, it gives an overestimation. And other measurement errors include too much or too little fluorescein in the tear film, high astigmatism and scarred cornea. Non-contact tonometer is based on the principle of air pulse firing and measuring the reflected collimated light by the sensor. It is easier to use with no operator bias and no anesthetic is required and there is no risk of cross-contamination. Eye care is based on the principle of rebound tonometry. It is fast, patient-friendly and can be used in children too. The aim of our study is to compare the intraocular pressure measured by non-contact tonometer, eye care, Goldman apprenation tonometer in different IOP groups. It is a cross-sectional hospital-based study including 201 eyes of 101 patients. The ethical committee approval was taken and written informed consent was taken from all. The patients were recruited from the outpatient glaucoma clinic in Arvind Eye Hospital, Tirunelveli, with age more than 28 years, and the exclusion criteria were all the corneal pathologies, including central corneal opacities, high astigmatism, dry eyes, ocular trauma, or any history of ocular surgery in within 3 months. It was a single-day examination and all the patients underwent a thorough slit lamp examination. The IP was measured in sitting position in NCT, eye care and GAT sequence with a gap of 10 minutes to avoid any after-measurement fluctuations in IOP. The CCT was measured, results were cross-masked and the IOP and CCT values from the both eyes were taken with right eye first and then the left eye. These are the instruments used in our study. Based on the IOP of GAT measurement, the patients were divided into 3 groups. Group 1 of less than 10 mm of mercury, Group 2 11 to 20 and Group 3 21 to 30. The data management and analysis was based on Stata 14.0. The average comparison between the methods were compared using pair t-test. The mean differences in IOP in 3 measuring devices were plotted on Bland-Altman plot. The relationship between the different IOP measuring devices were made using Pearson correlation coefficient and a p-value of less than 0.05 was considered as statistically significant. Results. The mean age of our study population was 63.11 years with 54 men and 47 women. The mean difference in IOP measured in overall study population, GAT versus NCT, was 1.42, GAT versus eye care was 0.67. The mean difference in IOP when compared to GAT in Group 1, the NCT had 1.18, eye care had 0.59 and in Group 2, NCT had 2.16 and eye care had 2.10, whereas in Group 3, NCT versus GAT mean difference was 2.75 and eye care versus GAT was 2.19. The tolerability was defined as plus minus 3 mm of mercury and variability as plus minus 5 mm of mercury. The tolerability was less and variability was more for NCT in high IOP groups. Pearson correlation and interclass correlation showed good consistency between the 3 methods in each IOP group. The Bland-Altman analysis showed a mean difference of 1.51 between GAT and NCT and 0.76 between the GAT and eye care in overall population. The scatter diagram between CCT and IOP by 3 methods showed NCT was most influenced by the CCT followed by GAT. Discussion. A number of studies have been conducted but the results remain controversial. Our study compared the IOP values measured by NCT, iCare, and GAT over a wide range of IOP in glaucoma patients. Similar to Guler et al. Study, our study showed that the mean difference in overall population for GAT versus iCare was lesser than GAT versus NCT. Just like Minchin et al. Study, our study showed low tolerability and high variability for NCT in high IOP groups. Hence, NCT seemed to overestimate the IOP in high IOP group, whereas iCare showed a higher agreement with GAT over a wide range of IOP. The Guler et al. And Cato et al. Studies also reported similar positive correlation between IOP measured by all the three methods with CCT, similar to our study. Limitations. This study does not eliminate the measurement bias in various glaucoma types. The sample size of patient included in low and high IOP group was relatively small. A larger astigmatism range could have been taken. To conclude, IK showed a better agreement with GAT when compared over a wide range of IOP. The consistency between the three tonometers was similar in low IOP range, where there was an overestimation with NCT in high IOP groups. The CCT seemed to affect IK measurement the least when compared to GAT and NCT. Hence, IK could be used as a great screening tool and an effective alternative to GAT. Thank you.
Did you compare the CCT you have given in a table in that?
Yes,
CCT
ma'am.
measurement?
Yes, ma'am.
And did just show that table?
Ma'am, the NCT was most affected by CCT.
Okay, just that.
After that, GAT, and then least was IK.
Okay. Another thing, you didn't compare with the axial length.
No, ma'am.
Okay.
Thank you. Thank you. Thank you. So the next speaker is Dr. Hemanti Chaudhary.
Good afternoon, respected judges and my dear audience. My paper is Novel Artificial Intelligence Derived Dry Eye Analyzer. Is it here to stay? I have no financial disclosure in this presentation. DUCE 2 in 2017 have published the renewed definition of dry eye disease, and though the definition and the classification of the disease is seemingly clear, no gold standard test for diagnosis exists. A Google search of setting up a dry eye clinic yields more than 3 million results in less than half a second, and the literature review of imaging in dry eye shows multiple devices like corneal topography, AIOCT, wavefront aberrometry, infrared thermography, tear film imager, tear lab osmolarity system, Inflamma Dry. And it is of course not possible for a single ophthalmologist to obtain all of these. This is where the multi-imaging integrated device comes into play. Our purpose is to evaluate the role of novel artificial intelligence derived dry eye analyzer in patients with ocular surface disorder. It is a prospective study. Our sample size is 250. All the patients underwent ocular surface disease index questionnaire. Then they were subjected to dry eye analyzer. The traditional test of Schirmer and ocular staining were also performed. In the AI-derived dry eye analyzer, they were first subjected to non-invasive breakup time, tear meniscus height, infrared mammography, and lipid layer interferometry. The OSDI scoring were graded into mild, moderate, and severe, depending on the chart here. Non-invasive breakup time uses Placido's disc projection using visible light, and it looks for distortion of the Myers, and it gives the first breakup time, the average breakup time, the breakup distribution, and generates a map like this. Tear meniscus height is measured with an inbuilt camera, and it is this is measured in line with the pupillary center. This is a normal. The left side figure is a normal tear meniscus height of more than 0.2 millimeter, and this is an abnormal one in the right. Infrared mammography is based on the principle of autofluorescence of healthy mabum when it is focused with an infrared light and it is captured by an infrared coupled camera device. This is the first image that is obtained, and this is the second image which can tell us about the gland loss and the gland dropout. The figure on the left is a grade 1 MGD which has very minimal loss. The figure on the right has a loss of 78% gland loss, and this is a grade 3 MGD. Lipid layer thickness is based on interferometry. It is when a bright light falls on an oily layer, then in the figure over here, right bottom and right up, which is grade 3 and grade 4 lipid layer, you will see a lot of colorful fringes. But the figure on the left, if it has a thin oily layer, then the fringes are almost absent and it is a colorless pattern that we see. Our results show Schirmer was positive in 51% cases, and out of them 11% had severe dry eye, 38% of the patient had positive corneal staining, 18.8% had NI beauty less than 10 seconds, tear meniscus height was less than 0.2 millimeter in 9.4% patients. Lipid layer analysis have shown 51% of the patients having less than normal tear lipid layer. Mammography showed 56% of the patient had some form of meibomian gland disease. We have done a correlation between the various test parameters, and the figure which shows the minus values show that there were no correlation between these two tests. The figure in the green, the values on the green show there was a high correlation between OSDI and lipid layer, OSDI and mammography, Schirmer and staining, some correlation between mammography and lipid layer, a very high correlation between NI beauty and tear height. The overall results show that though all the patients were having signs and symptoms of ocular surface disorder, 23% of the patient did not actually have dry eye. This bar graph is showing the overall positivity in all the test parameters, and 9.2% patient had positive result in all parameters. So what we already know of this multimodality imaging devices is that these are automated, these are non-invasive, they do not require an ophthalmologist to make the diagnosis of dry eye. It is less time consuming and it makes the monitoring easier. So what our study adds, meibomian gland disease and abnormal lipid layer thickness contributes to more than 50% of the cases. Cases hetero missed by the traditional test. In this particular study, 14.4% could be detected by this device. Dry eye analyzer, when used in conjunction with traditional test, is complementary. Limitation being small sample size and monitoring patient's course over time was not done. What is the translational potential of the study? We can identify deficient layer of tear film. In that way, we can do imaging-based targeted therapy, and this is the color-coded map that is generated. So when we show this map to the patient, it helps to raise their awareness, and in a way, it can increase the compliance level of the patient. Thank you very much for your kind attention.
Thanks, Sumanti, for your wonderful presentation. Any question?
Thank you so much.
The next speaker is Dr. Alankita Hazarika.
Yeah. I think we can call the next speaker, Dr. Samira Naik.
Very good afternoon to all of you. Systemic bacterial co-infection in hospitalized COVID-19 patients has been reported to be 7% and it increased to 14% in presence of ICU admission. Systemic fungal co-infection in hospitalized COVID-19 patients are also not uncommon. There are anecdotal reports on presumed intraocular infection such as endophthalmitis. With this background, we did a study titled Sight-Threatening Intraocular Infection in COVID-19 Patients in India. It was a retrospective chart review of prospectively collected COVID-19 patients' data between April 2020 to January 2021 at L.V. Prasad Eye Institute, Hyderabad and Vijayawada. Laboratory confirmed cases of COVID-19 patients who presented to us for endophthalmitis management within 12 weeks of discharge from the hospital were included in the study. Data included age, gender, associated comorbidities, detail of COVID management during their hospital stay, detail of the drug intake during hospital stay, detail of microbiology, biochemistry of biosamples. A comprehensive eye examination was done for each patient. Endophthalmitis was managed as per the institute protocol. The vitreous sample was subjected to gram staining and chalcophrol white mount. It was inoculated on different solid media in different liquid media. Species identification was done using Vitek 2 compact system. PCR for Eubacteria, Panfungus, and Herpes virus was done whenever possible. Vitreous sample was also subjected to RT-PCR under appropriate cold chain for SARS-CoV-2 detection whenever possible. We included 33 eyes of 24 consecutive subjects. Cases of endogenous endophthalmitis coincided very well with the peak of COVID-19 in both states, Telangana and Andhra Pradesh. Mean interval of COVID-19 systemic symptoms to ophthalmic symptoms was 15 days. Mean age at presentation was 53 years. There were 17 males. 90% had systemic comorbidities and 9 had bilateral involvement. 66% had ICU admission and 8 patients had used ventilator during their COVID treatment. Majority had anemia, thrombocytopenia, lymphopenia, neutrophilia, and raised inflammatory biomarkers like C-reactive protein, IL-6, LDH, D-dimer, and serum ferritin. All had received broad-spectrum antibiotic. 58% had received tocilizumab. 87% had received systemic corticosteroid. The endophthalmitis, we included 32 eyes of endophthalmitis and 1 eye of panophthalmitis. The clinical picture ranged from pre-retinal and vitreous exudate to complete vitreous abscess and involvement of ocular coats and orbit. Mean presenting visual acuity was 0.0415. All had presented with pain, redness, blurring of vision. We could not do vitreous biopsy in 5 patients. 14 out of 19 had microbiologically positive vitreous sample, out of which 11 were fungi, 2 bacteria, and 1 virus. 11 out of 21 had some systemic focus of infection, out of which 5 were candidemia, 3 bacteremia, 2 aspergillus, and 1 mucormycosis. At a median follow-up of 90 days, 19 patients recovered and 5 patients deceased due to COVID-19 related complications. Ophthalmic management included vitreous biopsy, vitrectomy, multiple intraocular antibiotic, intrafungal antibiotic, intraocular antifungals, and sometimes silicone oil injection in presence of retina detachment or necrotic retina. Only 40% eyes had vision better than 2400 at the last follow-up visit. This is a 58-year gentleman. He presented with pre-retinal exudate Microscopy revealed fungal filament, and the species was identified to be Candida tropicalis. This is another gentleman, 59-year, who presented with retina detachment and choroidal thickening. The microscopy revealed septate fungal filament, and the species was identified to be Fusarium equisetae. This is another 65-year gentleman who presented with vitreous abscess, and the Gomori methylamine silver staining and Ginsa staining revealed septate fungal filaments, and the species was identified to be Aspergillus flavus. The limitation of this study is tertiary care referral nature of our practice could have skewed some of the clinical presentation, and lack of denominator of total hospitalized COVID-19 patients and their systemic comorbidities and interventions. So, endophthalmitis is a rare but not uncommon occurrence in hospitalized COVID-19 patients. It is associated with high mortality and blindness. Ocular infection is correlated well with hospitalization, ICU admission, systemic therapy, broad-spectrum antibiotic, corticosteroid, IL-6 inhibitors. Candida is the most commonest organism. Thank you.
Did you have cases of mucormycosis also along with this?
One case. This is in first COVID wave.
Okay.
At that time, mucormycosis was
not there. At that time, it was not there.
Yes.
You only had fungal other than mucor.
Yes.
Thank you.
So, thank you, Samira. The next speaker is Dr. Vineet P. Joshi. Dr. Joshi is the best paper winner from Telangana Ophthalmology Society, whereas Dr. Samira was from Andhra Pradesh State Ophthalmology Society.
Skipped slides क्यों दिख रहे हैं? Yeah.
Has Dr. Alankita Hazarika come?
Thank you.
Oh, you are here. Okay.
Can I start?
Yes.
Thank you for giving this opportunity. So I'll be talking about an anterior segment imaging solution using smartphones that we tried in teleconsultations. We have a financial interest with a grant supporting this work. So imagine if a patient is sending you a video or an image like this from his home. Wouldn't that save time and visit for you? And wouldn't that give you a lot of information whether how to manage the patient by sitting at home, where both the patient and you can sit at home and share quality images? This is the gold standard images that we have now, and it involves bulky devices with expensive equipments, and they cannot be transported to the areas of need, which are basically children, elderly, and patients with infections who were very much affected during the lockdown. So in such cases, you need technologies which are cost effective, and basically they should be in the hands of people who are in the bottom of the pyramid of care. Smartphone is one such technology. The cameras are very advanced, but they are basically tuned for distance photography, not for macro photography of ophthalmic grade, where the optics, focus, illumination is not tuned for ophthalmic grade. So how do we bridge this gap? So what we try to do is, with this study, is build a universal smartphone attachment along with an app that can solve the problems for the patients and make this device available for patients in their own hands, in their own phones, at their own homes. So what we did is, during the first wave of COVID, we got a lot of images from patients on WhatsApp, and we analyzed them, and we found out that the main things that they are lacking is they don't understand what is the clinical frame of interest for the doctors. There is a lack of focus, there is shake, lack of standard lighting and magnification, and as a result 84% images were not clinically good for clinicians. Plus, there is a variety of devices in a patient's hand, and they will not have the high-end phones. They'll have the mid-range phones, and the camera specifications vary. There are some devices in the market, but they were targeted mainly towards the clinicians, but none of the devices are basically targeted for the patients. So we tried to build a universal attachment. We worked in sync with engineers, and we tried to compare the gold standard imaging quality with what we were trying to develop. So we came up with a hardware which is a universal clip-on system with an app. The app kind of does most of the work. It simplifies the work for the patient, wherein I'll just show you how it goes. So in the first part of the study, where we compared the images captured using this device and app with the slit lamp photograph, and we saw that more than 70% of images were of fairly good enough quality, and the clinicians were accepting now almost to 53%, which was a significant improvement. So we finalized this protocol of how to capture the images, and then we converted it into the app. And then what happened is that the app basically adjusts the illumination, magnification to such a level that the patient just has to go and tap on the screen. The image is captured with the date, and it is archived and uploaded in the cloud. So all the patient has to do is tap. So we gave this in the patient's hands, and all you can see here are the images captured by the patient's relatives. So all those 4 parameters, which was lack of perspective, focus, illumination, resolution, improved significantly. And there was, so there is a loss of adherence to protocol. That is where the app came into the picture, and it increased the adherence to the protocol. So overall acceptance by clinicians increased further to up to 66 to 70%. So this was one of the first attempt where the primary focus was patient as the end user, and not a doctor or optometrist or any technician. The patient knows how to use their own phone well more than others. We are just augmenting their ability to help them capture good clinical grade images. So here we tested it on all mid-range smartphones. We found a particular focal length which kind of suits most of the phones, and it actually eases the job. So here, basically, it is aimed towards identifying the at-risk cases with a need to referral to higher centers. This can be automated using AI, and also decrease the risk of, save the time for the doctors as well as for the patients in teleconsultation. So this is the Grabby Light. We have trademarked this product. So this is the our team at Center for Innovation, LBPI, have been working hard behind this for the last 2 years. So this is the product, where it's a simple device, and the app interface is somewhat like this. You can archive the images and send it to the doctor in any way. So one of the patient from Jammu Kashmir, this is the image captured plain just with the smartphone, and this is with the device and the app. So it's good enough for me as a cornea surgeon. Tells me some sutures are loose, some are good. Overall, there's no congestion, no infection, and it's a very simple training process. Anyone, you don't have to sit and train the patient yourself. Any staff, any faculty can be able to do this. We do it at the optical store in LVP, and it actually helps save a lot of time, and patients really get it very easy. So that's the circle. They have to bring the cornea in the circle and tap. That's it, and you get a good quality image. So the idea of social impact strategy was that you can save a lot of visits for the patient. Like for example, this patient, we actually saved close to 10 visits for him, which was about 4 months of time, and managed him completely based on smartphones. So in the last 2 years, there has been increase in teleconsultations, quite a huge number. And the economic footfall we know is that we have saved up to 79 million rupees because of just of this environmental impact. And I feel that this device can add to this. Thank you.
Thank you so much. Very nice presentation, Dr. Joshi.
Thank you.
And next, Alankrita.
The last speaker.
Last speaker of the session.
Dr. Alankita, yeah. She's the winner of Best Paper from Ophthalmological Society of Assam.
Greetings to all the respected judges and delegates of AIOC2022. Myself, Dr. Alankrita Hazarika, from postgraduate trainee from Assam Medical College and Hospital. The topic of my paper presentation is acute ocular complications in patients undergoing radiotherapy for head and neck cancer. So starting with the introduction, radiotherapy is the treatment of choice in patients with low-grade ocular head and neck cell tumor and other head and neck cancer. It offers an alternative to enucleation for patients with intraocular tumors, but may end up with a myriad of other ocular complications as seen in figure 1 and 2. Radiation-induced ocular morbidity encompasses a spectrum from transient eyelid erythema to complete loss of vision. Acute ocular complications presents within 3 months of therapy and occurs either as a direct result of the radiation for intraocular tumors or when the eye is within the entrance or the exit beam. So the aim of my study is to observe the various acute ocular complications in the patients undergoing radiotherapy for head and neck cancer, and my objective is to evaluate the type of complications. My study was a hospital-based prospective study consisting of 85 patients undergoing radiotherapy for head and neck cancer attending the Department of Ophthalmology and Radiation Oncology AIMS Dibrugarh from July 2020 to June 2021. So the inclusion criteria includes all the patients diagnosed with head and neck tumor undergoing radiotherapy and patients of all age group, whereas the exclusion criteria consists of patients receiving simultaneous chemotherapy, cases with known pre-existing ocular disease, patients with systemic disease, autoimmune diseases, and blood dyscrasias. All these patients underwent complete ophthalmic examination including detailed history, base-corrected visual acuity was noted, Schummer's test and tear film breakup time was tested, slit lamp examination and fundus examination was done. Periodic follow-up of these patients was done till 90 days of the therapy. So the statistical data that was collected was tabulated in Microsoft Excel worksheet, and these categorical variables were then summarized as proportions and percentage. The table 1 shows all the acute side effects found in the study population, of which dry eye consisted the highest amount, accounting for 20% of the study population, followed by mydriasis 7.05%, erythema 5.89%, pigmentation and meibomitis 3.53% each, and lastly dermatitis and conjunctivitis 1.18% in each category. No case of radiation retinopathy was found till 3 months of follow-up. This is a graphical representation of the complications found in the study. And coming to the discussion, Lana et al. In 2004 reported that 76.5% of the patients receiving radiotherapy for tumors of head and neck experienced acute ocular side effects, which is high compared to that of ours, which is 42.05%. In 2012, Bhandare et al. Mentioned in their study article that incidence of dry eye syndrome increased steadily from 6% at 35 to 39.99 grays to 50% at 45 to 49.99 grays. In our study, radiation dose ranges from 40 to 60 grays. In a study by S. Maharia et al. In 2019, dry eye was found in 33% cases as acute side effect of radiotherapy for head and neck tumors, whereas in our study, dry eye accounts for 20% of the cases. Nuzi et al. Described an overall incidence of 16% of cases of eyelid complications in their study. Jagannathan et al. Showed the onset of mydriasis only for doses greater than 50 grays. In our study, as mentioned earlier, the radiation dose ranges from 40 to 60 grays. Mettler and Upton mentioned that the initial skin reaction is seen within 2 weeks of fractionated external beam radiation therapy. A study done by D. Chen et al. In 2018 showed diffuse meibomian gland loss in both the eyelids of the diseased eye 12 months after the onset of radiotherapy. In our study, 42.05% of the patients underwent radiation treatment for head and neck cancer, and these patients presented with acute ocular complications which include dry eye, followed by mydriasis, erythema, pigmentation, meibomitis, and dermatitis and conjunctivitis. Acute ocular complications in patients radiated for head and neck cancer is unavoidable, but these complications can be minimized or delayed using modern radiation techniques and with proper protective measures. Thorough clinical examination leads to early detection of these adverse effects so that timely and specific treatment will restore vision, thus preserving the normal ocular function. Lastly, I would like to conclude my study with the photographs of this patient found during the study period. So, figure 6 shows mydriasis in a patient with basal cell carcinoma after radiotherapy. Figure 7 shows conjunctivitis in a patient with sebaceous carcinoma during the process of radiotherapy. Figure 8, dermatitis in a patient of adenocystic carcinoma of lacrimal gland post-radiotherapy. And lastly, figure 9 shows pigmentation in a patient of maxillary carcinoma post-radiotherapy. These are my references, and thank you for your patient listening.
Thanks, Dr. Alankita, for a nice presentation. With this, we come to the end of the session, and I congratulate all the speakers. Presentations were very good, and thanks a lot.
Thanks for finishing in time. Thank you, everybody. I think it will be compiled. May I request all the speakers to come and have a group photograph. Some.